Thank you for joining my presentation on Adult Critical Care Specialist Review. This particular lecture is going to be talking about laboratory values, cardiovascular conditions, shock, and sepsis. My name is Terrence Shenfield, and I am the co-owner of A&T Respiratory Lectures. We are now in the cardiovascular section, and we have a few slides to talk about cardiovascular disease. We're going to be talking about palpation, which is basically, you feel someone's pulse, you just determine the rhythm, the power of the pulse. You look at inspection, you look for venous distension. We also look at auscultation, where you're looking at different heart sounds, the S1, S2, S3, and S4. And one of the key points regarding inspection is you could look at neck veins. If you see significant jugular vein distension, that the neck veins protrude, it's often caused by a variety of things. It could be right heart failure, it could be central venous pressure elevated, it could be COPD, it could also be congestive heart failure. So using these tools, which I'm going to get into more details for each one, can determine what kind of condition the patient has. And they're not going to really tell you the patient has right heart failure. They're going to give you a series of descriptions that you should be able to figure it out and then understand the treatment option. So let's talk about heart sounds. You know, you have your S1, your S2s, your S3s, and you also have a murmur. Your S1 and your S2 are normal heart sounds, and it's basically talking about closure of the valve. So your mitral valve and your tricuspid valve are your S1 and S2. Your S3 and S4 are valves. If you happen to hear a heart sound with S3 or S4, that means you got some kind of problem with your heart. And S4 is attributed to left ventricular dysfunction. So you should know S1, S2 is normal. It's mitral and tricuspid valves. When you start going to the S3s and S4s, then you got some other issues going on. And also, sometimes they might describe a patient with cold, clammy skin. When they say someone has cold, clammy skin, think MI, think myocardial infarction. And what do you got to do? You got to do an ECG immediately. And basically, how you identify an MI is elevated ST segments on your ECG. So I just wanted to go over some basic things. Just know S1, S2 is normal. S3 and S4 indicate something's wrong. S4 is more indicative of left ventricular dysfunction. And if someone has cold, clammy skin, think MI. What do you got to do? You got to do an ECG. And also, if you do an ECG and you see elevated ST segments, what do? You think the patient got an MI and you got to treat them for the MI. So when we talk about pulse and blood pressure, there's certain values you should know. For example, when you're talking about blood pressure, you should know normal values, which would typically be 120/80. You could talk about someone who may be hypertensive with a blood pressure of greater than 140/90. And then you might be thinking about hypotension, which is a blood pressure less than 90/60. So you should understand basically these values, because some of the questions on the exam may put some values out there and you just got to understand exactly what it means and maybe what kind of remedies or treatment options you could offer. Also, when you review the pulse, typically a weak and thready pulse indicates poor cardiac output. A strong and bounding pulse may indicate hypertension. An irregular rhythm may indicate some kind of cardiac problem. So in other words, some of the questions will talk about a weak and thready pulse, and they might give you some blood pressure, that's hypotensive. They may also talk to you about someone with a strong and bounding pulse, which typically could be normal, but could also be associated with hypertension. So you should know some of these buzzwords. They like using these words on the exam, and you should know normal values. Let's talk about cardiopulmonary stress testing, also called exercise tolerance testing. Basically, They bring a patient to a lab and they put them on some kind of device, either a treadmill or a bicycle, and they really want to look at the heart and lungs and see how they do when they are doing some kind of exercise. So basically they want to stress the heart. They measure the ABGs, they measure EKGs, they measure blood pressure, they measure heart rate, and they want to see how your body reacts to certain stress. Now, when I took the exam, there was a question about this, but they were saying that the patient could not walk on a treadmill due to some kind of hip surgery, but they really needed to determine, their exercise tolerance testing. And so there are certain conditions where you could do cardiopulmonary stress testing by chemical induction. Basically, there are certain chemicals that stress the heart, such as adenosine, Lexiscan, and the third one. So just understand that you should know the names of these medications, and you should realize that sometimes they want to do a stress test, but the patient can't do it for some reason, and that's why you have to do a chemically induced stress test, and these are the drugs that they would offer. Another type of test that could be done at home or at the bedside is called Holter monitoring. And basically, if you have some form of cardiac event and they bring you in for an EKG and they can't pick it up, sometimes they'll send this home with you to see what kind of rhythms may occur over a 24-hour period. It's also used post a cardiac, if you have like an MI, they might want to do that too. So basically, it's a monitor that's attached to your chest with some leads. It's good for if you suspect ventricular tachycardia. It's also good if you suspect atrial fib, atrial flutter, even bradycardia. So basically, you put this monitor on the chest. You look at a normal, it's while you're at rest. It's not put you under stress. You're not under stress with this. And they just look at your heart rate and they look at any kind of rhythms that may occur over a 24-hour period. And it's a very handy device. So you should just know a little bit about that and know some of the tests they do it for. And it's not potentially life-threatening. So that's one of the key points. Let's talk about some more additional cardiac diagnostic testing. They have a test called Cardiac Electrophysiology Study, EP or EPS. Basically, this is a minimally invasive assessment of the electrical activity of the heart. And what you can do with this test, if someone has arrhythmias, this is a great test to determine arrhythmias. It's a lot better than the EKG. And it's also something you should know about. The patient has to be NPO 12 hours prior to the exam. So remember, cardiac electrophysiology study is used to determine arrhythmias, and that it's much better than the 12-lead EKG, and the patient has to be NPO for 12 hours prior to the exam. The other test that you could do is called a cardioangiography. Basically, you're going to do coronary artery catheterization, and what you really wanted to look at is blockage in the coronary arteries. Also, it's a great test for plaque, a narrowing of the arteries. So I'm sure you've heard of this. It's called coronary artery catheterization. And the final one is an echocardiogram. Basically, this can visualize the heart valves, and it could also determine valve problems. It could also determine murmurs. It could also determine congenital heart defects. So these tests are, and the echo is done obviously through sound waves. So just understand that they got many different tests for cardiac issues, and you should know a little bit about each one as you go along with the exam. Now we're going to get a little bit into cardiac conditions such as congestive heart failure, and we're going to start off with this. Congestive heart failure could either be chronic or acute. The primary issue with congestive heart failure is the left heart. The left ventricle cannot pump blood out effectively. Eventually, after time, when you have congestive heart failure, it could work into the right side of the heart too. So just understand it's primarily the left side of the heart, but it can work its way into the right side of the heart. The problem is the ejecting of all the blood out of the ventricle through the lungs, and this actually causes a problem where the blood backs up into the lungs and it actually decreases pulmonary efficiency. Basically, you get pulmonary edema, and then when someone's oxygenation decreases, so their PaO2 will go down. And if you have someone on mechanical ventilation with this, you may want pulmonary edema is treated with PEEP. And, these are, pretty common, especially with patients with cardiac disease. When you think about acute congestive heart failure, it looks just like severe respiratory distress, and it can cause failure of the left heart again. One of the common signs of congestive heart failure is venous distension. You have a protruding neck veins. So you have a little idea how congestive heart failure works. Now we're going to talk a little bit about the treatment options for it. So a treatment option for congestive heart failure is to offer Lasix. Lasix reduces the work of the heart. It basically removes excess fluid, and so Lasix is one of the primary choices for congestive heart failure. Another good option is to give 100% oxygen to lower the work of the heart, especially in acute conditions. Finally, you get isotropic medications such as digitalis. Digitalis will improve the contractility of the heart, so the left ventricle can pump better. So these are your basic treatment options for congestive heart failure. Now, we all heard of coronary artery disease, atherosclerosis, and this is when the coronary arteries, which are arteries that surround the heart, they supply blood and oxygen to the heart muscle itself. Over time, they could get blocked by plaque, and as a result of that, it could be difficult for blood to flow through them easily, and then the heart muscle doesn't get the oxygen and everything it needs. Over time, this will weaken the heart, and you might end up going into congestive heart failure, or you might have cardiac arrhythmias. And, we all know about this, and so just be a little bit cognitive of this. Another thing you should know about is pulmonary hypertension, especially the treatment options. For example, what is pulmonary hypertension? Pulmonary hypertension is when the pulmonary arteries, which are in the lungs, they are hardened, and they make it very difficult for the right heart to pump blood into them. What happens is, because of the difficulty of the right heart to pump blood into those arteries, the right heart enlarges, and ultimately it becomes, you go into heart failure, right heart failure. Hemodynamically, pulmonary hypertension manifests itself by increased PAPs and also elevated pulmonary vascular resistance. So from a hemodynamic point of view, you should know the values for pulmonary PAPs, and you should know the values for PVRs. It also could be caused by left heart failure over time, as we mentioned earlier. The typical treatment options, the ones we know about, we know Flolon, we know inhaled nitric oxide. We also now know that even Viagra works very well for pulmonary hypertension, prostacyclins, and also hydralazine is another choice for that. So understand the mechanics of pulmonary hypertension, understand hemodynamic values, and there'll be a whole course on hemodynamics, and understand the treatment options for this. So let's turn our attention to hypertension, a very common issue here in America. Usually hypertension is diagnosed when the blood pressure is greater than 140/90. There's multiple ways to actually lower blood pressure. You could increase the contractility of the heart muscle through medications. You could also reduce blood volume by administering diuretics such as Lasix. You could cause vasodilation through a whole host of medications, which I'm going to show you on the next slide. And also you could increase cardiac contractility with digitalis. And other ways to reduce blood volume is to increase urine output, and which you understand will cause excretion of potassium, sodium, and water. So these are some of the methods to manage hypertension, and then I'm going to get into the medication side on the next slide. So here are some of the treatment options for treating hypertension. You could do it through direct-acting vasodilators as nitrates and nitroprusside. You could also do calcium channel blockers. And also the third choice is an antagonist of the renin-angiotensin-aldosterone system. So these are the basic pathways to manage medications and manage hypertension. And what you should know, you should recognize some of these names on the exam, and we do cover the pharmacology aspect of the exam on a different presentation. So just understand what these drugs are. We now turn our attention to shock, and there are different types of shock. There's anaphylactic shock, there's neurogenic shock, there's cardiogenic shock, and so on, and also septic shock. So when we think about shock, one of the most common things you need to understand to manage shock is fluid administration. That is your initial treatment for everything. So if you get any question on the exam regarding any kind of shock, really you got to think about fluid administration. Regarding anaphylactic shock, we all have heard about that. That is when you become exposed to some kind of foreign substance. It could be a bee sting, it could be pollen, it could be some kind of food allergy, it could be a protein that you eat, or it could be a medication. Whatever the case is, anaphylactic shock is really, really bad. Basically, there's a great increase of histamine during anaphylactic shock. It's the deadliest type of shock. And the problem with anaphylactic shock is it could swell your airways. For example, my son has a peanut allergy, and we really watch to make sure that he doesn't have any kind of nuts, because that kind of shock, anaphylactic shock, could make inflammation of your tissues of your throat, of your tongue, and you can end up stop breathing. Treatment options, like I said, when you think about fluid administration, you also got to think about epinephrine. So anaphylactic shock is managed through fluids and epinephrine. So those are your choices there. And just understand, anaphylactic shock is one of the most deadliest shock out there. The next type of shock we're going to talk about is cardiogenic shock. And so you might ask, what are the main causes of cardiogenic shock? It could be inflammation of the heart muscle, commonly known as myocarditis. It could be the infection of the heart valves, endocarditis. It could be a weakened heart from any cause. You can have some, heart disease, congestive heart failure, coronary artery disease, anything like that. It could be drug overdose. It could be poisoning. All of these things can impact the heart and cause cardiac shock. What are the signs and symptoms? Rapid breathing, severe shortness of breath, sudden rapid heart rate, tachycardia, loss of consciousness, weak pulse, low blood pressure, sweating, pale skin. So all of these things are the signs and symptoms of cardiogenic shock, and you have the main reasons why it occurs. And I'm going to go a little bit more about the treatment options on the next slide. To further our discussion about cardiogenic shock, I wanted to go a little bit more highlights of it. Typically, you have a severe drop in blood pressure due to damage or dysfunction of the heart. So you'll definitely be hypotensive. You'll have lack of sufficient blood flow to key organs in the body. You may have elevated ST segments, pronounced Q waves. And so these are some of the signs and symptoms, as I mentioned earlier on the previous slide. Some of the short-term solutions, you have short-term solutions, you have long-term solutions. The short-term solutions is you could give epinephrine, you could give dopamine, you could give dobutamine, you could give all these choices as a short-term option. Long-term solution depends on the cause of the shock. Exactly what was wrong. Was it a valve problem? Was it an infection problem? You may have to do a coronary artery bypass graft. You may have to do catheterization and angioplasty. There's so many different choices that goes along. It all depends on the etiology of your cardiogenic shock and what your treatment options are. But knowing the short-term solutions is relative because it can save your life. Septic shock. You're going to absolutely see some questions on the exam regarding septic shock. Typically, they will say that the patient has an indwelling catheter and it's noticed to be red and inflamed. Also, there's a severe drop in blood pressure. And so what do? Obviously, you're going to give fluid administration. You're also going to get rid of that catheter. You're going to take that catheter out, maybe put a new catheter in. So typically, indwelling catheters are the most likely source of septic shock. What is septic shock? Septic shock is widespread infection. It could be caused by viruses. It could be caused by bacteria. Once in a while, fungal in nature. What is the treatment option? Fluid administration, antibiotic therapy. If the patient needs CPR, you give them CPR, corticosteroids. Also, sometimes patients who are diabetics go into septic shock, so you really have to manage their blood sugar effectively. There's a treatment called drotregocagon alpha, which has really been shown to be quite useful with the patients. So septic shock risk factors: if you have a suppressed immune system, suppose you're HIV or you're on chemotherapy, and then you show signs and symptoms of shock, that could be it. Extreme age. Typically, shock occurs with the infants and in the elderly. That's where it's mostly occurring. Also, organ transplantation is another common source of septic shock, a surgical procedure, indwelling catheters. So these are the things you got to watch out for. And remember the treatment options: fluid, antibiotics, corticosteroids, drotregocagon alpha is another good choice. And just make sure you manage the sugars, and you definitely give fluid administration. So that's septic shock. Sepsis is quite complex in its processes. It's almost like COVID-19 in the inflammatory response that occurs. Basically, the body is subjected to some form of infection, and that causes an inflammatory response where chemical mediators are released. This inflammatory response actually involves adapted immunity, humoral and cellular responses, where the B lymphocytes and the T lymphocytes release all these chemical mediators. As a result of this, local cytokines are produced and released, which further puts more insult into the body. And then as a result of that, these unregulated release of pro-inflammatory mediators, the cytokines, this elicits some kind of cellular damage going on in the body. So it's really quite complex. Cell damage proteases, which is basically, these are enzymes that degrade proteins, they occur in excessive amounts, and this causes fever, tachycardia, ventilation perfusion abnormalities, acidosis, and clotting cascades. So really kind of complex what goes on, and it's very serious, and the treatment options for these patients is kind of low, but we're going to talk a little bit about more of that on the next slide. We have no shortage of shock conditions. Let's talk about hypovolemic shock. What is hypovolemic shock? Hypovolemic shock is a shock that is caused by a lack of fluids in the body. What kind of things can occur to make a lack of fluids? It could be a motor vehicle accident where you have an internal bleed. You could have dehydration. You could have vomiting. It could be significant diarrhea. You could be hemorrhaging. You could have a GI bleed. These are all common causes of hypovolemic shock. So it usually occurs over a short period of time. So you have some kind of damage going on in your body, and then you have a quick response that you're hypovolemic shock. What do? You administer fluids and blood or blood products such as plasminogen. Also, you need to give some IV fluid administration of dextran. So these are the common causes of shock, like I mentioned: dehydration, vomiting, significant diarrhea, GI bleed, motor vehicle accidents, internal bleeding. All of these things could cause hypovolemic shock. What do? You got to manage the fluid administration with blood products and other fluids to bring up the blood pressure of the patient. Let's talk about neurogenic shock. Neurogenic shock is a shock where there's a loss of blood pressure due to damage to the brain or the spinal cord. And basically, it could be caused by inflammation. Some of the common signs of neurogenic shock is bradycardia, clammy skin, also loss of consciousness. What are the causes? What causes neurogenic shock? Typically, the most common cause is spinal cord injury, some kind of spinal cord injury. It could also be done by autonomic nervous system toxins. It could be some medication, something you take, but something that impacts the brain. It impacts the blood pressure, your heart rate, everything. Really severe. It could be also Guillain-Barré syndrome. How do you treat it? What are the treatments? You got to understand the underlying etiology, what caused the neurogenic shock. You got to give fluid administration. You may need to give dopamine. You need to increase cardiac contractility. You may need to give antidiuretics. You have to maybe give atropine if bradycardia is present. So that is the management options of neurogenic shock. So just remember, it's caused by a spinal cord injury. It could be caused by toxins. It could be caused by Guillain-Barré. Signs and symptoms include bradycardia, inflammation, severe loss of blood pressure, drop in heart rate. You really need to do something quickly about it. Fluid administration is your choices. Dopamine is another choice. A vasopressin, antidiuretics, atropine if you have bradycardia. So these are things that are signs and symptoms of neurogenic shock and some of the treatment options. And I also mentioned some of the causes. So now we're going to turn our attention to sepsis. So what is sepsis? Sepsis is an infection in the body that leads to an inflammatory response that can be severe, that actually you could go into multi-organ dysfunction, you could die, you have circulatory dysfunction. Sepsis is really serious. There's a high morbidity and mortality rate with that, especially with patients who are immunocompromised, especially with patients who are older or younger. The incidence of sepsis is about 3 cases in every 1,000 people. It's really severe, and it's caused by infection, and it really can progress really rather seriously. I'm going to talk a little bit more about that on the next slide. Sepsis is quite complex in its processes. It's almost like COVID-19 in the inflammatory response that occurs. Basically, the body is subjected to some form of infection, and that causes an inflammatory response where chemical mediators are released. This inflammatory response actually involves adapted immunity, humoral and cellular responses where the B lymphocytes and the T lymphocytes release all these chemical mediators. As a result of this, local cytokines are produced and released, which further puts more insult into the body. And then as a result of that, these unregulated release of pro-inflammatory mediators, the cytokines, this elicits some kind of cellular damage going on in the body. So it's really quite complex. Cell damage proteases, which is basically, these are enzymes that degrade proteins, they occur in excessive amounts, and this causes fever, tachycardia, ventilation perfusion abnormalities, acidosis, and clotting cascades. So really kind of complex what goes on, and it's very serious, and the treatment options for these patients is kind of low, but we're going to talk a little bit about more of that on the next slide. So what is the treatment options for sepsis? It starts with antibiotics. You have to understand exactly what kind of infection is going on with the body and then treat with the appropriate antibiotic. Obviously, due to the hypotension that is caused by sepsis, you really need to start using intravenous fluids as soon as possible to get the blood pressure up. And finally, you need to use vasopressors. Vasopressors actually narrow the blood vessels, which will increase blood pressure. So these are your typical choices for the treatment of sepsis. Regarding sepsis, you need to really pin down exactly what causes sepsis. First of all, sepsis occurs in over 65% of the patients who are over the age of 65. So it is a disease process of the elderly. The cause of sepsis can be many. It could be pneumonia, it could be a urinary tract infection, it could be meningitis, it could be wound infection, it could be endocarditis, it could be a catheter-related infection. And so any of these conditions can cause sepsis. But sepsis may start first as systemic inflammatory response syndrome, which I'm going to get a little bit more into in the next slide. So let's start off with a definition of what is SIRS. It's systemic inflammatory response syndrome. Basically what it is, it's a systemic inflammatory response to some kind of insult to the body, such as an infection, a trauma, surgery, acute inflammation, ischemia, malignancy, to name a few. So basically you have this exaggerated inflammatory response system with the release of cytokines and pro-inflammatory mediators and all of these other things that wreak havoc in the body. So a preset to sepsis can be SIRS. So how do you diagnose SIRS? To diagnose SIRS, you need two or more of the following. You need to have a body temperature greater than 100.4 or less than 96.8 Fahrenheit. You need to have a heart rate that is greater than 90 beats per minute. You need to have a respiratory rate that's greater than 20 breaths per minute. You need a partial pressure of CO2 less than 32. And you need to have a white blood cell count greater than 12,000 millimeters or less than 4,000 millimeters cubed, or greater than 10% of immature neutrophils or bands. Just remember, you just need to have two of those things. So either your body temperature is higher or lower, your heart rate, you're a little tachycardic, you're tachypnic, your PCO2 is less than 32, and you have some form of infection based upon your white blood count. So I wanted to go over some definitions with you. A patient with systemic manifestations of an infection plus a documented infection, that patient has sepsis. So how do you define someone with sepsis versus severe sepsis? Severe sepsis is if you have an infection and it's documented, but you also have organ dysfunction, tissue hypoperfusion, and sepsis-induced hypotension, then you are considered to have severe sepsis. What is tissue hypoperfusion? This is defined by an elevated serum lactate level, and a normal lactate level is anywhere less than 2 millimoles, but if you have anywhere from 2 to 4 or greater, that means that you have tissue hypoperfusion. And then finally, what is sepsis-induced hypotension? That is a systolic blood pressure greater than 90, or a mean arterial pressure greater than 70, or a decrease in systolic blood pressure of greater than 40 millimeters below a normal setting. So these are some definitions that you should know. You know how important it is. I say the most important one, know your lactate levels. So what is acute organ system failure? We all know what organs are. It could be your heart, it could be your brain, it could be your liver, it could be your kidneys, it could be your intestines. If any of those organ systems go down as a result of sepsis or some other condition in your body, there are signs and symptoms that are recognized. For example, from a cardiovascular point of view, you know, you're going to be tachycardia, you're going to have arrhythmias, you might be hypotensive, you're going to have elevated central venous and pulmonary arterial pressures. From a respiratory point of view, you're going to be tachypnea, you're going to be hypoxic, and from a renal point of view, you're going to be producing small amount of urine, and you're going to have elevated creatinine levels. All of these are signs and symptoms of acute organ failure based upon the organ that it impacts. But in this case, we're talking about cardiovascular, we're talking about respiratory, and we're talking about renal failure. When evaluating signs of acute organ system failure, you have to look at different systems. For example, you have to look at neurologic systems, GI system, hepatic system, and hematologic systems. Regarding the hepatic systems, increased D-dimer levels is an indication of clotting. A normal level is 0.5 and below, but anything above that would be something to be concerned about. You know, you have some kind of clotting factor going on. You know, it could be a PE, it could be some other type of clot. You listen to ileus sounds, you know, listen for absent bowel sounds. You know, you can look at albumin levels, liver enzymes, so many different things. And neurologic, you're looking for altered consciousness, confusion, psychosis. So when you're thinking about acute organ system failures, you have to look at different systems in the body, and you would have to look at normal values for each one. Now we're going to put our attention into the different disease processes that can impact the ICU patient, and something that you need to know for the adult critical care specialist. For example, you need to know about ARDS. You need to know some stuff about acute renal failure, GI complications, disseminated intravascular coagulation, DIC, multiple organ dysfunction syndrome, otherwise known as MODS. So you got to know a little bit about these things, because these kind of questions will be on the exam, and you just got to have a basic understanding of them. Let's talk about something that we're kind of familiar with, and that's ARDS. ARDS stands for Adult Respiratory Distress Syndrome. It typically occurs with blood transfusions, trauma. It could be caused by sepsis. It could be caused by near drowning. It could be by inhalation of toxic gases. So, you know, there's a whole host of things that could cause ARDS. But you should recognize the common signs and symptoms. And the common signs and symptoms are severe hypoxemia, and which I mean by that is a PF ratio of less than 200. A PF ratio of less than 300, from 200 to 300, could be considered acute lung injury. But also some people now label ARDS in different levels, like mild, moderate, and severe. But from what I know, anything a PF ratio less than 200 is ARDS. Anywhere from 200 to 300 could be acute lung injury, or it could be mild ARDS. It all depends. When you think about ARDS, there's three different stages. There's the acute stage, the fibrotic stage, and the resolution stage. During the acute stage, there's profound hypoxemia, there's inflammation, and there's diffuse alveolar damage. So that is what happens there. At this point, during the acute stage, this is when you want to do a low tidal volume strategy. You want to use high levels of PEEP, low tidal volume, because this is a time when you really want to protect the lung from any kind of further damage. Once you become fibrotic, that's when you see decreased compliance and increased dead space. At this point, you'll see your peak airway pressures climbing really high, and this is a time when you might want to consider inverse I ratio pressure control ventilation, APRV. You might want to use some kind of open lung strategy during this time. Resolution takes anywhere from 6 to 12 months, and so this is, severe based on the ARDS and the management. Morbidity could be almost up to 50%. So these are the three phases of ARDS, and the phase that you can have the biggest impact as a respiratory therapist is at the acute stage, where you might want to manage them on mechanical ventilation with a low tidal volume strategy, the odds net strategy, and so on. Another condition you need to know about is DIC, or called disseminated intravascular coagulation. Basically, it is caused by a clotting factor in your blood that forms these clots in your blood. Basically, they block small blood vessels, and what happens is they deplete the platelets in the body, and as a result of that, there's an increased risk of bleeding. So what happens eventually, at first you clot, then you bleed. Then there are fibrin deposits in organs which cause ischemic damage and failure. So this is a cascade of events that occur due to a clotting factor, and it's called DIC, or disseminated intravascular coagulation. I'm going to give you, the next slide is going to tell you how they actually diagnose this. So how do you diagnose DIC? Basically, it involves a combination of laboratory tests and clinical evaluations. What you're looking for is low platelet counts, elevated D-dimer concentrations, decreased fibrinogen concentrations, and prolonged clotting times. So these are the tests that they do to determine whether you have DIC, and then they come up with a treatment plan based upon that. Another thing to familiarize yourself with is MODS, multiple organ dysfunction syndrome. This occurs when two or more of your organs are damaged, such as your kidneys, your liver, your lungs, your brain, your heart. All of them could be affected, or maybe just at least two of them will be affected. The mortality rate is anywhere from 27 to 100% based upon the number of organs failing. My next slide is going to be going into the diagnosis and how do you actually diagnose MODS. When diagnosing MODS, early detection is key. The earlier you realize that some organ systems are failing, the better. Aggressive treatment, which I'm going to go on the next slide, is going to tell you about, can decrease mortality by 30% for septic patients and up to 50% for non-septic patients. Some typical lab tests include serum electrolytes, also complete red blood cell counts, also coagulation studies, blood gas analysis, cultures of sputum, urine, cerebral spinal fluid, and wound drainage. All of these things are very good at treating the patient and reducing the mortality of the patient. This is a treatment bundle that consists of many different things, and I'm going to go into each detail a little bit later. But basically, these patients are hypoxic, and they could benefit from 100% oxygen via a non-rebreather. Also, you need to obtain 2 separate blood cultures before antibiotic therapy. One is an aerobic blood culture and the other was an anaerobic culture on different sites. You need to initiate antibiotic therapy based upon the type of bacteria you have. You need to initiate fluid resuscitation. You also need to measure the patient's lactate and hemoglobin A lactate levels, and you also need to insert a urinary catheter to monitor urine output. All of these things are the treatment bundle, and I'm going to go a little bit more detail on the next slides. So with these patients, they're really sick, and their metabolic demands because of their illness may require intubation and mechanical ventilation. So that is why you really need to monitor the patient with ABGs. You need to look to see if the pH decreases, if the PCO2 climbs, if the, you have to look at the blood gas. Also, you want to get blood cultures, and the goal is to obtain 2 separate cultures, one percutaneously and the other one via vascular access. Why you get 2 separate blood cultures? Because it really helps determine whether this is a true bloodstream infection, rather than a local infection. So that's the purpose of that. Regarding antibiotic therapy, a broad spectrum antibiotic is used initially to, cover any kind of organism the patient has, and normally is discontinued in 3 to 5 days. Once you identify the organism, by going to microbiology and knowing exactly what kind of organism it is, you could actually modify the therapy based upon the culture. A single antibiotic therapy may last 7 to 10 days, but it may be longer in patients who are immunocompromised or if they have an undrainable infection. Also, the dosage is adjusted based upon renal function and clearance of the antibiotic. So these are some of the pearls of wisdom for antibiotic therapy. The primary goal of fluid resuscitation is optimize hemodynamics when a patient is in shock. So this is the cornerstone of sepsis therapy too. Regarding the fluids that are used, typically you'll have crystalloid solutions such as sodium chloride or lactated ringers. You will also may give colloids such as albumin, because you want to maintain a value anywhere from 3.4 to 5.4. You also want to do this to maintain mean arterial pressures above 65 millimeters of mercury. You also want to maintain your wedge pressures between 6 and 12 and your CVP pressures between 8 and 12. The whole purpose of fluid resuscitation is to keep your hemodynamics in order. And also you may want to give a fluid challenge to these patients based upon their blood pressure and urine output. So these are some of the key points you need to understand about fluid resuscitation. Regarding lactate and hemoglobin levels, you really want to look at this. Septic shock is diagnosed when the lactate level is greater than 4 millimoles in the presence of severe sepsis. So if you see a lactate level greater than 4 in the presence of severe sepsis, this is named septic shock. At this point, you also want to consider a blood transfusion if the hemoglobin value is less than 7. So these are some of the pearls of wisdom. If you get, when you take the test, they might just say someone's hemoglobin level is 5. What do you suggest? And they might, and the answer is give them a transfusion. So learn these little values and learn these different values based upon the patient's condition. So let's talk about the medications which are the cornerstone of managing shock and sepsis. Antibiotics. You need to give a broad spectrum antibiotic as soon as possible because you really need to manage the underlying infection. Once you get some cultures and you determine exactly what organism is, you could fine-tune your antibiotic. When we talk about hemodynamic stability, vasopressors is the way to go. Norepinephrine is the drug of choice. So when you think about hemodynamic stability And if you're thinking about vasopressors, think about norepinephrine. Sometimes patients are hypotensive and they don't respond to fluids or vasopressors. So what do you got to do? Consider corticosteroids. They've actually been shown, some good studies showing it really helps patients who are not responsive to normal means. Then finally, there's a drug out there that it's good for the treatment of severe sepsis and actually reduces the risk of death by 20%. The name of that drug, and I have a slide on it next time, is Drotraga alpha. And this medication has worked very well with these patients who are septic. So the medication that I mentioned is good for severe sepsis and septic shock and those who are at a high risk of dying. The patients who you give this medication have to be selected carefully. You just can't just give this to every patient who's septic, but if someone is in severe sepsis and there's a high risk of them dying, this is a good choice. The FDA warns that you do not give this medication who had a one organ dysfunction and also who have undergone surgery and who's a high risk of death. So these are some of the contraindications. It's also contraindicated in patients with active internal bleeding. So remember this name because when I took the exam, this was on the test, and that's why I put this extra slide out for you. I want to thank you for joining this presentation, and I have some listings of some good references that you could use for studying this test. Obviously, Kettering and Lindsay Jones are really good sources, as well as my partner, Albert Ure. He has a very comprehensive respiratory therapy exam preparation guide. So hopefully you do very well during the exam.